of at least, and the reason why you would use them. One is a compression view. So that's a compression view of that spiculate area behind the left nipple. That's an M5. As I said previously, radiologically classified on mammogram, classified on ultrasound, clinical examination, the surgeon will classify, and biopsy, the pathologist will classify. So that's an M5 lesion in the left breast, which says that it is a cancer. It's a spiculate lesion. If you were to describe it, you can say that this is a spiculate lesion measuring approximately 15 millimeters. It's sited in the retroareolar region as seen on CC view and on the MLO view, approximately 10 millimeters behind the nipple. It does not appear to be involving the nipple. It is also seen on compression view, where it is seen more prominently as a spiculate mass. It has irregular margins, and appearances are suggestive of a cancer. The other thing that you should look for are any axillary lymph nodes. So if there are any obviously abnormal axillary lymph nodes, they will be seen projected over the pectoralis major muscle. But in this case, we don't really see any. It does not mean that there aren't any, but it's a good thing to comment on it and say, I will look for the lymph nodes on ultrasound. Of course, this patient will have an ultrasound of the left breast to look for the cancer and to perform a biopsy. On the other side, again, there is an area of asymmetry. So in order to get to the bottom of this, there is a compression view, also called a paddle view, that has been performed. The reason why this is done is so that it allows for dissipation of any glandular tissue, because like chest x-rays, there are lots of composite shadows in the breast, and the way to get rid of these is by compressing it. So this is an indeterminate area, M3, and therefore they had a compression view for this. So up until now, we've seen the MLO views, that is the mediolateral oblique, the CC craniocaudal, and the compression views. So there are further views that could be employed for things like microcalcification. So this is the right breast MLO and CC views, and it shows an area of microcalcification in the lower half of the right breast. So line drawn back from the nipple going towards the pectoralis major muscle on the MLO. The area below this line, there is microcalcification. You may or may not be able to see it on this particular screen. In order to size it, we need to magnify the images. We could actually have dedicated magnification views before we decide whether the patient requires a biopsy. And that is what has been done in this case. So on the magnification views, you can see the calcification much better. You can size the extent of it, which is important in determining whether this patient can have a wide local excision or requires a mastectomy. And again, the grading on mammogram M4 is suspicious, bordering on, I think this is a cancer. So, so this is M4 microcalcification. Between M3 and M4, if you're struggling between an M3 and an M4, I wouldn't worry too much. It's fine to call things an M3 or an M4, because what you're essentially saying is, I am concerned enough about this for this to undergo a biopsy, for the patient to undergo a biopsy for this. And that is what has to come through. What is your management going to be on the basis of these numbers? One point I would like to raise here, I've seen a lot of people say, and I can see peau d'orange, well, peau d'orange is a clinical diagnosis. It is orange peel, and it occurs because there is tethering of the Cooper's ligaments, and the skin in between bulges out. So this is a clinical diagnosis. What you can see on mammogram is thickening of the skin. And of course, where the cancer is and the skin is attached there or involved there, you can say that it is tethered. But please do not speak about peau d'orange on mammogram. Okay, so onward with the cases. This is a 65-year-old woman who was seen in a symptomatic clinic because she felt lumps in both breasts. So she was seen by the surgeon, and the surgeon could feel these lumps, and she was sent for radiology. So on the right side, on the MLO view, which is the lower one there, you can see quite a dense lesion, which is sited quite posteriorly, just overlying the pectoralis major muscle, the lower border of the pectoral muscle. And again, it brings to the fore the importance of including the inframammary fold, of pulling the pectoralis major muscle onto the mammographic plate. This could very well have not been seen on this image. Also, if you notice on the MLO view, the skin overlying it is attached to it, it's tethered to it, and there is some air within the skin fold, which tells you that the skin is at least tethered, if not involved at this point. So it's in the lower half on the MLO view, and posteriorly from the nipple, so quite centrally on the CC view. So the way I would describe this is, this is a 65-year-old woman who's come to the symptomatic clinic with a well-defined lesion. On the right side, it's well-defined. Its anterior margin is well-defined, but I cannot see the posterior margin very well. What I can see of the anterior margin looks quite irregular, and this is in the lower half of the breast centrally, so probably in about the 6 o'clock position. And since it is sited as posterior as it is, I am concerned that this is involving the pectoralis major muscle. Also, I can see skin tethering. I do not see any abnormal lymph nodes. The one lymph node that I can see projected over the right pectoralis major muscle looks normal, but I will evaluate this with ultrasound. All in all, on mammogram, the appearances are suspicious for a cancer, and this is an M5 lesion. And again, not to forget the other breast. Always comment on the other breast. Where you do it is not important, but do comment on it. So on the left side, we see a couple of rounded densities, the most prominent of which is quite dense and appears calcified, and this is in the upper outer quadrant of the left breast. So line drawn back from the nipple, the bigger rounded lesion is in the upper half of the breast on MLO view, and on the CC view, it's in the outer half of the breast, so upper outer quadrant of the breast. And this could be a cyst with a calcified wall. It could even be an oil cyst, and it's probably long-standing. You will say that, you know, I will compare this with previous mammograms, and more likely than not, these rounded areas are will be seen on the previous mammogram. There is another similar appearing lesion, which is in the inner half of the left breast, right back from the nipple. So it's in the inner half. This would be at approximately the 9 o'clock position. If you're comfortable, give the clock face, but do not feel compelled to say it. It's safer to say the quadrant. 12 and 6 o'clock, you're safe because you're not going to make a mistake on upper half, 12 o'clock, lower half, 6 o'clock. But when it comes to 3 and 9 o'clock, because it's different for the two breasts, and if you're not comfortable, you don't have to use the clock face at all. So appearances of the lesions in the left breast, well-defined, rounded lesions. They have a halo surrounding them, and on comparison with previous images, if these were present, it tells me that they are benign lesions. So these are M2 benign mammograms on the left. So to perform an ultrasound of the left breast, and I'm just going to pause that and go back. So that's the calcified rounded lesion that was seen in the upper half of the left breast, and you can see how it's casting a shadow posteriorly, but it is a curvilinear shadow that it's causing, and this tells you that it is indeed calcified. This is not a lesion that I'm worried about. Moving on. Okay, so the other thing to look for when you're looking at the ultrasound images is look for the ultrasound marker and where it is. So this is the right breast, the right axilla, the marker is in the lower half of the right breast, which would correspond to the lesion we saw on the mammogram, which was in the lower half in the 6 o'clock position. That's about right. And again, describe this mass. This is well defined in most part, but slightly ill defined more laterally. And it is quite a heterogeneous but hypoechoic lesion with irregular margins. Measuring whatever the size, always to be looked at in 2 planes. That is elastography, one of the investigations that can be done for breast lesions, also for thyroid lesions, to look for elasticity. So how bouncy is the lesion? And that shows quite a few areas of red, which essentially says that this is not a very bouncy lesion. And it tells you that it's most likely going to be a cancer. It is a cancer, really. Okay. Right, because we commented on how posteriorly sited it is, it would be good to comment on involvement of the pectoralis major muscle, on involvement of the rib. And that's what you see there. So where the rib has been marked, it doesn't look like it's involving the rib. Of course, ultrasound is operator dependent. It depends on how you interpret the ultrasound images. Once they're taken, it's a bit difficult to interpret. But where you see something marked for you, it's a good thing to pick up on that and comment on it. There is a trend in the FRCR exams of asking for and putting in more ultrasound images. So good to use all the information that you have. And those are images through the axilla. So on the right side, you can see the right axilla, and that's a lymph node in the right axilla. Fatty hilum, it has quite a well-defined thin cortex. This is not one that says abnormal. So this is a normal lymph node. Okay, another normal lymph node there. Okay, on the point of normal lymph node, let me just show you a couple of abnormal lymph nodes. So this is a different patient. Again, looking at the skin marker, it's in the left axilla, and this is a rounded lymph node. It doesn't matter what the size is, this is rounded and it is hypoechoic. So it has lost its normal fatty hilum, and this looks quite abnormal. So this was a lymph node that was replaced with metastatic disease. Another example of an abnormal lymph node, the length of the lymph node is not really important, although that's what's been measured there. If you look at the cortical thickness, it's not absolutely uniform. You can see the hilum, which is the hyperechoic linear bit within it, which is sort of just pushed to one side, and the cortex on the superior aspect is quite thickened as compared to the inferior bit, if you look at the marker. And this is an abnormal lymph node. So abnormal lymph nodes, as far as the breasts are concerned, rounded, hypoechoic, loss of fatty hilum, or displaced, irregularly placed fatty hilum, thickened cortex. More than 2.5 millimeters is what is followed at a lot of places, but there are some institutions where it could be more than 2 millimeters. Just see what is acceptable for the place that you work at, and anything above that you would perform a biopsy on. Again, biopsy is whether it would be a fine needle aspiration, so cytology, or a core biopsy. Either can be done. Also, focal cortical irregularity is another thing that would tell you that the lymph node is abnormal. Okay, the next case, a 65-year-old woman screening mammogram. So this woman was called for her screening, was invited for screening, which she took up, and she had her 2-view mammograms, MLO and CC views. So these are the mediolateral oblique views, right and left, and you can see that there is a spiculate lesion on the right side, which is right back from the nipple, almost in the center of the breast. So if you draw a line back from the nipple, it's really on that line. On the left side, you can see the nipple in profile, and behind that, there is another increased density. So if I was looking at these mammograms in the exam scenario, I would say that these are fatty mammograms of the 65-year-old woman who has come for screening mammograms. They are adequate in that I can see the intramammary folds and the nipple, at least on the left side. I have yet to see the CC view. The pectoralis major muscle is not seen all the way down to the nipple posteriorly, but it's possible that there were some difficulties with performing this mammogram and therefore they're not seen. Comment on it. You don't have to say the mammogram is rubbish, but you could say that it's not seen all the way down. And looking at the CC view, on the right CC view, you see the spiculate lesion. So it's well-defined but irregular margins, spiculate, which essentially says this is a cancer, and this is in the outer half of the right breast. On the left side, again, slightly more difficult to see, but it looks like in addition to the nipple, there's something that's sitting behind there. And so this is in the inner half of the left breast. So to summarize always, bilateral screening mammograms, fatty breasts showing a spiculate lesion in the outer right breast and a small indeterminate area in the inner half of the left breast, for which the patient will be recalled to an assessment/radiology clinic and investigated with further views of the mammogram, which could be compression views or something called a digital breast tomosynthesis, which I shall show you in a minute, and also ultrasound and a biopsy will be performed. At the same time, when the ultrasound is being done, ultrasound of the axilla will also be undertaken. So the diagnosis was bilateral breast cancers, just showing you the digital breast tomosynthesis. And it is moving very slowly, but it is moving. And you can see the spiculate lesion coming into view and going away. So it's a tomosynthesis. It's almost like, you know, the tomosynthesis of yore, where it was performed for the kidney. You're basically taking slices through the breast. Just to show you once again, taking slices through the breast, and at some point this becomes really prominent and you know that there is a cancer that's sitting there. Similarly, on the left side, the cancer in the left retroareolar region is not really very well visible. It was suspected on the screening mammogram, but a tomosynthesis was performed, and if you look at it really carefully, there is a small little lesion that's sitting there approximately 15 millimeters behind the nipple, and that turned out to be a cancer. So on ultrasound, the right breast and the left breast. So this is the right breast, 3 centimeters from the nipple in the 9 o'clock position. There's this spiculate lesion, which is quite ill-defined really here, irregular margins, and you can see that this is causing what we call a posterior acoustic shadow. So this is a single lesion that is seen in the right breast, approximately 3 centimeters from the nipple, and in the 9 o'clock position. It has irregular margins, it is spiculate, it is causing posterior acoustic shadowing. The other thing that I would say is taller rather than wider, to indicate that it is a malignant lesion, although this is not something that is always true. What I would say for this lesion is that it is breaking the continuity of the breast tissue. It is causing a distortion there. It is causing a break in the normal architecture of the breast. So in between those fat lobules, you suddenly see this thing coming and disrupting it, which tells me that this is a breast cancer. And that's on the left side, so left inner half. You're seeing a spiculate lesion, again, breaking the symmetry of the breast and causing a bit of posterior acoustic shadowing. And this is classically taller rather than wider, which tells you that it grows across planes rather than along planes. So a benign lesion will grow along planes. This is a malignant lesion. It is crossing planes and disrupting the architecture. So the next case, a 35-year-old woman with a left breast lump, and she had serial ultrasound scans. So this was in 2014, and in the left breast, the outer half of the left breast, as can be seen by the marker there is a well-defined hypoechoic oval lesion, which is wider than taller. It's going along the tissue planes. It lies parallel to the skin. It does not cause any disruption of architecture. It appears to be sort of going along the tissue planes and separating them as it is growing. So there is posterior acoustic enhancement in this case. So there's more brightness behind the lesion, although not as much as, but similar to what you would see on a cyst, for example, in a liver cyst. So you're seeing posterior acoustic enhancement there, and that tells you that this lesion is benign, most likely a fibroadenoma. This is what happened to the lesion a year down the line. So as I said, she had serial mammograms, serial ultrasounds. She's 35. She wouldn't have mammogram at this point. Mammograms would be done at age 40 and above, unless, of course, she was high risk, in which case we could start at 35 under the NHS BSP. Okay, so in 2015, she came back with this lump, which she said was increasing in size, and now it is more than twice the size of the previous, as seen on the previous ultrasound. It's about 56 millimeters in length, but it has maintained its oval shape, growing along the planes, posterior acoustic enhancement. It's not really invading anywhere. It is probably has a few cystic spaces now, but it still looks quite benign. So this is a fibroadenoma. It was a fibroadenoma that had increased under hormonal influence. So this woman was pregnant, and that's what happened to the lesion. Given that there are little cystic spaces within it, you could also be concerned about phylloides. So that is the other differential when it comes to fibroadenomas. At the outset, when you look at a lesion that looks benign, you could say that this is a fibroadenoma with a possible differential of phylloides. It's not a diagnosis that you need to make on ultrasound. It is a biopsy diagnosis. Okay, the next case, this is a symptomatic clinic patient who had come with a right-sided breast lump. I'm only showing you the right MLO and CC views. So this is a solitary appearing lesion in the central right breast, as seen on MLO view, and this lies in the outer half on CC view. So if you were to put a clock face, you would say in the 9 o'clock position of the right breast, it is well defined and largely has regular margins, except in its superior portion where it shows quite irregular, almost a spiculate kind of appearance. Commenting on the rest of the breast, this is a fatty breast. It is adequate. The nipple is seen in profile. The inframammary fold is seen, as is the pectoralis major muscle. I would look at the other breast and comment on it. I would also look at previous mammograms to see if this lesion was present. At this point in time, I would also recommend an ultrasound to evaluate this lesion better and perform a biopsy. So on the basis of the mammogram, I would give this an M4, if not an M5. Again, I wouldn't be too hung about what exactly is the number that you put on, because essentially what you're saying is, I'm concerned about this, I need to take this further, I'm not going to let this person go home. But do put a number on it and say at the end of it, to summarize, this is right breast lesion, probably malignant, M4, solitary. I would proceed with an ultrasound. So she had a right breast ultrasound, and that shows this partly well-defined lesion with cystic spaces, which you could think maybe a fibroadenoma or even a phylloides, except you're not really seeing part of its margin very well. And there's this spiculate area, which is quite cancer-like which you can say is irregular, has irregular margins. It is well defined, it has irregular margins, it is taller rather than wider, it is disrupting tissue planes, causing posterior acoustic shadowing, and you are concerned that this is going to be a cancer. So go ahead with a biopsy through both these areas and await biopsy reports. So there were two lesions here actually. Lesion 1 was an invasive ductal carcinoma, and lesion 2 was the fibroadenoma with cystic degeneration. So the one that was reasonably well defined with cystic spaces was a fibroadenoma with cystic degeneration, and it had a carcinoma that was literally opposed to it, almost attached to it. But fibroadenomas per se are benign lesions, and transformation into malignancy is not something that we see. The next case is a symptomatic clinic patient with a left-sided lump. This is a young patient, and this is the patient had come with a left-sided chest wall lump. So ultrasound performed showed a well-defined hyperechoic lesion, which is deep to the muscle of the chest wall, and this measures approximately 27 millimeters. It does not cause any posterior acoustic shadowing. The part of the shadowing that you're seeing there is because it's on the chest wall. That's part of the rib that you're seeing there. There is some internal vascularity seen within the lesion on Doppler, and the possible diagnosis is, of course, this could be a vascular malignancy, it could be a sarcoma, but it could be a hemangioma. So those would be your differentials at this point. What would you do next? You would not at this point go ahead and biopsy the lesion. Could perform an MRI to confirm this appearance. And that is what we saw on the MR. It's deep to the muscle. It is a fat-containing lesion, and the arrow on the right points to the lesion itself. The arrow on your left points to the feeding vessel. So there was vascularity within this lesion. This is a hemangioma. It's within, it's intermuscular, between the muscles, so deep to one of the muscles that you saw. Next case is a 39-year-old woman who was seen in a symptomatic clinic, and she had a left breast lump. So the MLO and CC view, left breast, quite a well-defined lesion. So this is how you would present it in the FRCR exam. So these are the MLO and CC views of the left breast. The mammograms appear adequate. I can see the pectoralis major muscle and the inframammary fold. I cannot really see the nipple in profile, but I would like to change the shadowing and check for nipple in profile. This shows a mixed fatty and glandular background pattern with a couple of rounded lesions in the upper outer quadrant, which measure XYZ centimeters. On the basis of what I see, you could say that this looks indeterminate. So giving this an M3 category, I would compare with the previous mammograms, and I will look at the other side, and this patient will go for an ultrasound. So left breast ultrasound. This is a reasonably well-defined lesion, which is 35 millimeters, heterogeneous, irregular margins. If you look at it on one of the views on the left, it looks like it's wider rather than taller. But if you look on the next image on your right, it is quite tall as well. It is disrupting tissue planes as well. So it's not really one that has entirely benign appearances, although you could say that maybe there's a bit of posterior acoustic enhancement. There definitely isn't any posterior acoustic shadowing. So this is a lesion that has mixed features. So it has irregular margins, which goes against it being a benign lesion. It is wider rather than taller. So that goes against it being, or rather in favor of a benign lesion. But it has quite angulated margins as well. So again, that worries us as regards malignant pathology. Also, there's disruption of the architecture, which again tells us that this doesn't really look benign. So all in all, if you were to call this lesion on ultrasound a U3 or U4 lesion, I would call this a U5 lesion because I'm concerned this is a cancer. But even if you were to say that this is a suspicious lesion or an indeterminate lesion, so U3 or U4, and I would go ahead and do a biopsy, that would be perfectly acceptable. And this turned out to be an adenoid cystic carcinoma. Now that is a pathological diagnosis. It is not something that will be expected on the imaging. Just found it interesting, and therefore I put this in. Adenoid cystic carcinoma, I'm sure you know the ones in the salivary glands, and they're spread along nerves. It does not really happen that way with the breast, and although it is a very rare cancer as far as the breast is concerned, it's not